Hi, everyone. My name's Yasmeen. I'm the Director of Training and Operations at TheraPsil. And my pronouns are she, her, and hers. And I'm conducting the Zoom call on the traditional and ancestral territories of the Squamish, Musqueam, and Tsleil-Waututh nations. And that's where I live, work, and play, also known as North Vancouver. I also recognize that our team advocates for the use of psilocybin in a Western medical context, but the whole field of psychedelic medicines would not exist without the Indigenous knowledge keepers. The use of psilocybin mushrooms has been used for centuries as sacraments within Indigenous cultures. I also just wanted to provide a few updates for everyone of where TheraPsil's at before we get into our webinar. So from a TheraPsil side, we do have a new health minister. For those who don't know, Jean-Yves Duclos, and it's the first time that we've got a mental health and addictions minister, which is Carolyn Bennett. So very stoked to have those two in office. And to date, TheraPsil has supported 42 patients with their Section 56 exemptions and 19 healthcare practitioners, which actually expired today. So we're going to be advocating to get those healthcare practitioners such as yourselves their exemptions and to renew the exemptions of those 19 who have expired, one of which is Dave Phillips, who's here with you today. Just a few other updates. We are currently still undergoing our legal challenge. One of our patients is fighting for his exemption rights for Charter 7 and Charter 15 rights. We've submitted a mandamus application. We've gone to cross-examination, and right now we're waiting for our hearing date. So we are prepared to go to the courts for a charter challenge in, Adam's here. Hello, Adam. In the new year. So we are pushing hard. We're still advocating for regulations because regulations are what we need right now. It's what our patients need. So that's kind of where we're at. We're going full steam ahead into 2022 with our legal challenge, and can't wait to hear when our hearing date is. Another update from the research side, we have launched an observational research study in collaboration with Imperial College London and McGill, and all patients gaining Section 56 exemptions will be offered the opportunity to take part in that research study. There's tons of training updates as well, which we're going to be going over in this webinar, but just to name a few, we have brought on 3 new trainers. So we've now got 4 amazing TheraPsil trainers, one of which is the amazing Dave Phillips, who has taught 5 of the 8 cohorts to date with TheraPsil. It's a lot. And we're also going to be moving to an in-person training model where all of our cohorts moving forward will be in person. We're also planning some 2-day intensive informational psilocybin training for folks who don't quite meet our eligibility criteria but are interested in learning. And we're also trying to plan some supplementary modules to add on to our training, such as Indigenous teachings, nature relatedness, and the impact of music in psychedelic therapy. So that's a lot of talking for me. Thank you, Dave, for joining us. And if you just want to introduce yourself.
I will now. Can I make a bit of a request? Sorry that I'm just kind of springing this on you. Is there any way that I could see everybody and those who want to go off camera can thumbnail, or is it just not? Is that too much?
So Adam, I don't think that's an option, but Adam, do you want to chime in there?
Can you hear me? Yeah.
Yeah.
So it's a webinar. So the way we've set this up is that we won't be able to view the attendance. Yeah. Sorry.
No. I just like to look at the folks of it. Hi, everybody. It's so good to be with you. Always great to work with Yasmeen as well. And so I've been a mental health professional for about 35 years, mostly been a trauma-informed therapist here in the Fraser Valley, and but also marriage and family. I teach at university, and I've been a clinical supervisor for about 25 years. So done a lot of work in therapy with therapists. About 5 or 6 years ago, I began in the research, hearing about initially it was the use of MDMA for PTSD, and quite frankly, I didn't pursue that at all. I'd just been at a major substance use disorder conference the year before, and one of the keynote speakers had said that ecstasy was the most dangerous of all the street drugs, and I wasn't a drug guy, so I had no idea, and so I just said, oh, I guess ecstasy's bad, and it just was in my mind. And so when I read that about MDMA for PTSD, I just dismissed it. I said, well, I don't think there's anything there. But about 6 months later, I read another article that talked about the Johns Hopkins trials using psilocybin magic mushrooms for the treatment of anxiety associated with a diagnosis of a terminal disease. And I think just the fact that it came from Johns Hopkins University really added credibility to it for me. And so I began to look into it. And I'm sure, as with most of us, once I started to get into understanding the studies and what we're learning about psychedelics, I was in 100%. And over the next number of years, began to be mentored in the use of these medicines and therapeutic work. And then was just very, very fortunate to team up with TheraPsil a couple of years ago, as I was had a client who was dying of cancer, and she was, I think, the second person in Canada to get an exemption for her treatment. And then when we got our exemptions, TheraPsil approached me about developing a training module. And so we started that, and yeah, I think we're in number 5 right now. So it's been very exciting. Probably close to 80 therapists that will be trained, and health professionals in my cohorts, but also I think at TheraPsil total, we're probably looking at 100 by the end of the year, which is just so exciting.
Yeah, thank you so much, Dave. And thanks for all of your work with TheraPsil to date. We truly couldn't have done it without you.
Yeah.
And for the folks listening, we're going to be answering some common questions that come our way. We also got some questions sent in ahead of time, so we'll be answering those at the end. But if you have any questions that pop up throughout, please pop them in the Q&A section, and we will definitely try to get to them. And so, Dave, let's start off. Can you just give us an overview of the training program and what the different modules cover?
Okay, so one of the real challenges for us as we first began to conceptualize a course is it going to be a course for therapists, or will it be open to physicians and nurses? And of course, there's other health professionals, but those are the 3 most common ones that we're working with, is MDs, nurses, and therapists, and different kinds of therapists. And that was a real challenge, because if I make it too broad a training so as to appeal to everybody, that we really wouldn't be training anybody in a very specific way. So the course that we developed really is targeted specifically for therapists to hold space. Now, that doesn't preclude doctors or nurses, and I think my thoughts on nursing and this field, Yasmeen. I think they've got a very unique role to play, but it probably would, for them, it would mean probably some additional training or experiences in the therapeutic end of things. But it's really, the MDs that we have that had in our course, probably 20 altogether, there's a whole bunch of them. I think they would say to a person, just understanding the process from start to finish has been so useful to them, right? So they can get a good picture of it. So then I sort of said, well, okay, the biggest thing is we need to have both didactic and experiential learning, and for a number of reasons. I'll talk about the didactic first. So I made a decision early on that I wasn't going to frame the course as a graduate course in psychedelics. And so many of us are aware of the CIIS program in California, year-long program, wonderful program, and that if you really wanted to get really become knowledgeable about the full range of psychedelic therapy, I really recommend something of that depth. We, Bruce and I and Health Canada, were able to define kind of a basic knowledge structure. And so that we do require all our students through the 10 modules to be watching videos and reading articles and listening to podcasts that kind of hit all the main area, the knowledge areas. And so the 10 sessions are broken down. The first one, we introduce ourselves to TheraPsil and to the TheraPsil process, and how, what Health Canada requires kind of on the front end of that, and, where therapists end up in that process. The second session, we talk about the core competencies of a psychedelic therapist. So knowledge of psychedelics, spiritual intelligence, trust enhancement, these sorts of categories that are of competency that we say we really need everybody to be moving forward somehow in these 6 areas of competency. And then class 3, which is one of my favorites, I give my conceptual framework for why psychedelic therapy works, and try to tie in intentions and the nurturing relationship and how the mushroom is given to integration, the whole piece, how it ties together in a framework. And then we get going in class 4. We talk about how to assess readiness, and a big part of that is is a person not just medically cleared for this, but will they be able to find it to be a useful kind of experience in their life? I should say, Yasmeen, that right from the start, we established a learning objective was that participants in this training course will be trained to safely and effectively guide someone through all aspects, all 3 phases of the psychedelic therapy. And I should just say, sorry, my presentation has it so much tighter, but there is like 3 phases. It's a 3 model approach that we take in the training, which comes from both the Johns Hopkins and the Imperial College trials. So there's these the preparation phase where we assess for readiness, develop a relationship, do intentions work, and then the dosing session itself is kind of its own phase, and then the 3rd phase would be integrating the experience. So anyways, we get into class 4, we're assessing for readiness, and then we spend a lot of time on talking about how to establish a human-to-human relationship. This is very different than the therapeutic relationship that most therapists understand really, really well. It's not like it precludes that, but I like the way Rose Watts is the PI at the Imperial College trials, and she says, it's a human-to-human conversation. I'm just sitting down to get to know you. And that seems to be a very important dynamic for these initial conversations. And then we help them find out what they want from this experience. And that we call that intention work. And when you think of set and setting, this would be under the category of mindset. So we're trying to get the right mindset. What do they want? What patterns or obstacles of standing in the way of them living the life they want? I'll give you an example. It's very, very common for folks who are facing their death to be terrified of their life after death, or perhaps they're afraid of the pain of dying, or the pain of the medical therapies, or perhaps they can't imagine leaving their children alone, or whatever it might be. And so you hear this, a very, very common, very, very understandable kinds of anxieties that people have as they face their death. And then just to simply ask them, well, what would you prefer? That, assuming we can't, we're not medical professionals, we can't change your medical status. Well, how would you prefer your life to feel and to be experienced? And everybody says the same thing. They want to live mindfully. They want to live for today. They don't want to be ruled by fears of tomorrow. Many want assurances at some level of what happens after I die. Many want to have a settledness about their children. And so these then become their intentions. And so we help them kind of put that together in 3 or 4 sessions. Then we prepare them for the mushroom experience. And so then we move into class 6s and 7, where we talk about how the best expression I know, Yasmeen, is holding space, how to hold space for people as they travel into their altered states, how to do it safely. Right now we use mushrooms, so how to prepare the mushroom, how to involve ceremony into that, and then a good knowledge of what a psilocybin trip looks like. So there's a certain shape to most psilocybin experiences. We do our model is 2 guides, eye shades, and headphones with a playlist, and the standard dose of psilocybin would be 5 grams of dried mushrooms. And that's, like I say, a standard. And of course, there could be movements either way on that. So we do that. We talk about what to do with unstable trips, or what people might call bad trips, how to support people through that. And then we get into the 3rd phase, which is how to integrate these learnings. Integration is such an important part of it. As a matter of fact, someone in my group yesterday said, I like to think of it as the medicine, the psilocybin experience is like the wedding, and integration is like the marriage. And I thought, what a great way of putting it. That's really
Great
nice.
analogy.
Isn't that good?
Yeah.
And so then after we kind of put our integration model together, then we have a class focused on death and dying, not just working with folks who are facing their own death, but also ourselves, because
You have a cool exercise for that.
What's
module.
that?
You have a really cool exercise for that module, don't you?
Oh yeah, right. This is one of my co-teachers brought this to me. So we have everybody begin to prepare an epitaph and a eulogy, and we give guidelines of what's a good way to put that together, and then we spend time in class reading them to each other and talking. And those classes have been really beautiful, really, really beautiful. And then the 10th class, the last class, we talk about learnings, consolidation of learnings. We talk about next steps. Talk about becoming affiliated with TheraPsil's and whatnot, underground scene, and all of that. So then we look into the crystal ball. What could be done? So that's the didactic. It's incomplete without people having an opportunity, not only to have their own psilocybin experience, because it's very different than recreational psilocybin, and it's very different than MDMA and very different than ketamine. So I personally, my opinion is, you can't safely and effectively hold space for another person with psilocybin if you've not had your own high dose journey. So that to me is requisite. But the other is, how can we want people during the second half of our course learn to actually work in triads together with other participants in helping them prepare their intentions, develop the loving relationships, because that would then be the people that would go together to the retreat. So the people that you've been working with for a number of months would be the people that would be holding space for you, and you would hold space for them during the retreat. However, yeah, go ahead.
Sorry, Dave, can you explain what a high dose would be in this context?
Yeah, I mean, when we talk about dried mushrooms, the standard is called the therapeutic dose, just colloquially known as the therapeutic dose. But again, it's one that most university studies have kind of said this is that point, and it's 5 grams. Now, I understand that some people have questions about body weight, and that's, there is some evidence that body weight can make a difference, but probably not. That's probably more, we think, related to MDMA than it is to psilocybin. My own clinical opinion on the matter, for what it's worth, is that I think the dissolving, so to speak, the default mode network of the brain kind of becoming unhooked as the primary information hub. That mechanism, I think, is the requisite mechanism of change in the psilocybin experience. And for most people, that it requires about 5 to 7 grams of dried mushrooms to kind of get to that point. I used to work with, tried to, lower doses and whatnot, but inevitably I'd find that I would have to boost it anyways, and that became kind of a problem in the sessions. So I went back to the folks at Johns Hopkins and talked to them, and they said, no, we had the same thing. It's just best to go with 5 grams. That's kind of a standard dose. But again, those are just practice guidelines. They're not written in stone. But as you know, Yasmeen, right now, in order to do a retreat, we have to have our health minister give exemptions to everybody, and that's kind of where we're stalled on that. But it's just, I'll just call it a pause. We'll figure it out.
We're gonna figure it out. And folks, if you're ever interested in advocating, please email me at healthcare@therapsil.ca. I'll pop that email in the chat after, because it's your voices being amplified that's going to make the difference. And,
and let me, sorry, you're choppy there. Don't mean to interrupt you, Yasmeen, but let me just say, one of the common questions I have from folks regarding the exemptions is, isn't it more important for patients to get their exemptions as opposed to health professionals? And, I don't think it has to be an either or, first of all, but the reason it's really important that we train professionals in this space is there is an unbelievable growing awareness in the larger culture of the efficacy of this therapy for some of the most common mental health problems we face: depression, anxiety, addictions, PTSD. I mean, as a therapist, I've just named perhaps my entire client load, right? And as folks who have been, living in a very desperate place for years begin to hear the promise that this therapy holds. It doesn't work for everybody, but when it does work, it seems to work really, really well. Well, there's going to become a demand for that therapy. And like I say, through TheraPsil, we will have trained 100 by the end of this year. But what if 1 million people want this therapy? That's going to be an enormous bottleneck. And if we don't have trained professionals, it's going to back up into the paraprofessional or even to the kind of novice world. And, I think there's the potential, I don't want to be doom and gloom, but I'm just saying the potential of discrediting our movement through ethical issues, abuse issues, perhaps improper support, having people going through experiences when they're not ready for, all the sorts of things that are important in training professionals would come up. And that is a concern for me. So I don't think it needs to be either or, but I try to keep our health minister, when I do my advocacy videos, to say, if we don't give exemptions to caregivers as well, we're in big trouble.
Yeah, absolutely, Dave. And I just want to say the advocacy is what makes a difference. And it's what got the healthcare professionals their exemptions last December 1st.
In the first place.
Wild that it's December 1st today. And we have this webinar 1 year later. So advocacy makes a difference. And I'll also just say to folks on the call who don't know, in the first 9 days of Jean-Yves Duclos being in office, he granted 3 TheraPsil patients their exemptions and 2 Atma Journey Center clients or patients their exemptions. So I'm definitely hopeful with.
Yeah, we'll take some hope from that for sure. Yeah.
Yeah. And Dave, what have your main learnings over the last 5 cohorts you've taught? What have they been? We've had 8 training cohorts at TheraPsil to date, and 5 of which you've taught.
Yeah.
What are your biggest learnings in teaching?
Well, I mean, you mean from the point of view of the trainer?
Absolutely.
Well, in terms of my own teaching style, the biggest challenge for me is I've been doing this in Zoom, and like I even said to this group here, it's just a weird way of teaching. I thrive on the energy I receive, from people. So I've not been able to do that, and I learned in our first beta group and then in our second group that I needed to get out of the PowerPoint environment. We needed to be far more discussion oriented, because and so the challenge for me is how to deliver the core material, but also allow the beautiful discussion and conversation between members of the cohort, some of which have far more experience in certain areas than I do. So I don't want to think like I'm the only guy that understands things. And so that's been a real learning for me, is how to shape the course. Now, I love that we're starting to move towards live trainings, like intensive trainings. And I think those will, if our bar has been here, like really good, we've been good training, I think we could, really maximize the effectiveness of the training. What other thing have I learned? I've also learned that so many people in the space have had their own experiences, right? I mean, it's kind of funny, Yasmeen, I've never said this to you, but I think something happened in 2015. It just seems when you talk to people, so many people around 2015, 2016 started to wake up a little bit and get it, I mean, maybe that's because that's when I did it. I'm only hear it, but when I talk to, so many people, it almost feels like they just started moving in a direction. And I don't know if it's true for the folks who are on this call, if they can kind of reflect, hey, when did I kind of get interested in this? So maybe the universe was up to something, who can say?
Yeah, and Michael Pollan was
right. Yeah, and maybe that was it. Maybe it was Pollan's book. Yeah, I'm sure that's
something in the universe, though.
Yeah.
And you kind of spoke about a few challenges, Dave, but what have your biggest challenges been? I guess one being exemptions not coming through. But what are some
and not being able to have the experiential retreats, which I think would be just absolutely amazing. Anyways, what challenges I've had, the Zoom has been a challenge. I tell you, the folks who've been in my training you've done such a great job selecting the folks. And I know that it's such a high value for us as BIPOC and underrepresented populations. And so the diversity that we have it's just amazing, because I tell everyone here, I am super aware that I'm a white male. Okay. This is I should be the last person people are listening to on that basis, because we've not been good to mankind for the most part. But I feel so privileged that I've been given an opportunity to through my therapeutic experience, my own journey through my own recovery from childhood abuse, and then to see, like I say, the difference that the medicine makes. And maybe I was going to mention this earlier, to say that in my framework, as I teach therapists, it really is a paradigm shift of how we treat our clients. And I'm super person-centered, and I know most of our models that we use are person-centered, and I'm not suggesting that we're not person-centered, but this is even different than just person-centered. Even when I, as a therapist, if say you came to me for therapy, there would be something in the transactional analysis between the two, or the transactions between that we'd say is therapeutically important. This therapy, or I might even say that when you come in, I'm thinking about your problems. I'm thinking about what you brought in, how I could be helpful, what treatment plans, what models, et cetera. So I'm thinking about that kind of stuff, right? I don't think about this stuff in this therapy. I say, my job is to hold space for you, to make sure you're safe, to make sure that you feel cared for and nurtured, to set the context, like say a playlist, mushroom. But once we do all that, the therapy happens inside of you. It's between your own healing intelligence or your problem-solving agency, or however you might want to refer to this process that happens between all the factors that lend to a good experience. That's what happens. And when your brain heals itself, that's thorough. Right. And again, I'm always said, like, Dave, you gotta calm your passion down a little bit. It's like, it makes
I love it.
But no, but because it sounds sometimes like I'm saying it's a panacea. It's not a panacea. And really it's the therapy around it that really makes it kind of, like I said, long-term embedded in my life. And right now, the research would suggest that it's probably really useful for about 60 to 70% of people to take it. So that does leave us 20-30% of folks who don't find it super useful, or for whom it's just not a viable therapy. And our promise, the field's promise to those folks, is we're going to continue to understand and to learn and to mitigate that. So and I know we will. Yes. But you think of treatment-resistant depression, which is what they studied in the Imperial College trials. And to qualify for those trials, you had to have tried 3 different therapies, which could be a couple antidepressants and talk therapy in a period of 10 years with no noticeable shift to your depression. So in other words, our success rate with that population is kind of zero. Right? They are the ones who are no longer meet the criteria for clinical depression, major clinical depression, after 1 year, 60 to 70%. Wow. Now, is it 100%? No, it's not.
Oh, but it's
like I say, we still, but right. And it's not just that a huge number, relatively speaking, are being helped by this therapy. It's the depth of it. Like to the point that some people experience what we would have understood as a cure, right? Not everybody, but some people no longer are triggered. Some people no longer, they just live in a full sense of openness in their life. And again, we have to be very careful. We don't want to set up expectations to a degree that people feel like they've been let down. We need to make sure we inform people well. But having said that, so many of us in the space believe that this represents a fundamental change in how we are going to treat mental health problems moving forward, because our track record, quite frankly, as a field, has not been good.
And especially after the last 2 years, I think people are needing this kind of treatment more than ever.
Right. I mean, COVID certainly has exacerbated. We know that by numbers, right? And lots of different theories in that. For me, beyond the fact that there's so much uncertainty and people don't do well when there's anxiety, but it's disconnection. We are so disconnected from each other, and that's what's hurting us. And one of the beautiful outcomes for so many people who go through this kind of therapy is that they feel connected to themselves, they connected to their spirituality, they connected to the universe, and then they begin moving back into their lives, right, where they can be connected to people and whatnot. So I think connection is a big part of it as well.
Absolutely. And you've kind of led me perfectly into my next question. Why do we need regulations?
Yeah, I mean, you could answer that one as well as I'll throw my 2 bits in, but feel free to join me. I think you're the one who kind of said it to me, Yasmeen. I don't want a politician making decisions about my healthcare.
No.
And our doctors, I'll tell you, I know about 5 doctors personally, like they're wonderful people. The system is hard on them.
Yes.
It's hard for them to give good healthcare. It's not their fault. It's not because they don't care. And I think if we can get enough docs trained to be able to put this medicine into their hands, working with a therapeutic team, I think, you're going to see, we'll see it go to another level. But while we have to wait on the poor health minister to have to watch our videos and, go just keep being us nagging at them all the time and one at a time trickling out to us. I mean, obviously for people who pass away while they're waiting for their exemptions, how tragic is that? But I stay more focused on for the therapists and say, these are what do we have? Like hundreds of people on our waiting list, therapists who want to be trained in this.
We have 1,000
right?
people on our list.
Right. So that's my short answer. If you want to add to that, or
beautifully said, and I couldn't agree more. We've got 19 patients right now waiting for Section 56 exemptions, 114 healthcare professionals, with I think 120 more in the pipeline who are going to be doing training in the next 3 months. And the Section 56 exemption process isn't working anymore. It's simply not working. And like you said, Dave, this needs to be a decision between the doctor and the patient, and not politicians.
I did an interview on W5 last month or something, and after it was aired, my inbox was full. And my voicemail was full of people saying, I want this therapy. I want this therapy. I'm in Montreal, I'm in Toronto, I'm in Halifax, I'm in Calgary. How can I get this therapy? And I just I can't answer you. I can't, this is too many requests. And that's out there already. Right. And we have to get, wouldn't it be great if I could say, here's a list of 10 practitioners in your region who at the very least will get you onto a waiting list. So at least you know that you've been heard, you've been seen, and get you to the doctor. I just can't wait for that structure to be in place.
Yeah, thank you, Dave. And so the question that gets brought up all the time that I'll answer quickly is, who's eligible to apply for our training program? Yeah. And I'm just going to give you a few little bullets of what we look for, but I also want to let you know that myself and the training committee, which consists of Dave, Bruce, Human, Ingrid, and myself, myself and the other 4 trainers, we're working on a 2-day training intensive for folks who don't meet our eligibility criteria, but are interested in learning about psychedelic psychotherapy. So that's something that's coming. But currently for our training program, what is necessary is 5 years of experience in your field, a medical degree or graduate degree in psychology, counseling psychology, or closely related field. Current good standing as a professional member of a regulatory or provincial college. And preference is also given to folks who have palliative care experience and psychedelic experience. So in terms of the process, there's a long wait list. There's 1,000 people on it, as I mentioned. And I know this question comes up all the time. Where am I on the wait list? And so we go by region on where the training is, and then we go based on the region, based on area of sign up. So good news is we've got 6 cohorts that we've just announced for 2022, and that's just for the start of 2022. And while also hopefully scaling this new training program for the 2-day intensive, we really have plans to scale our training program in 2022 to meet the demands of our wait list. And so, Dave, final question before we go to the questions.
Let me just comment on that. I know that sounds like a high bar. I mean, I know that we're aware of that. And I know so many people who've got the right spirit. They're natural healers, but they don't necessarily have the credential. And I look forward to us having, like I say, a stream where kind of, for lack of a better word, call them assistant guides, or support guides, so folks can be in that space. And and that as we broaden it out to be able to give folks with giftedness a place. But right now, with where we're at, I mean, we have to kind of dance in the dance hall we're in, which is the Western medicine model. And it is what it is. And so that's why, from my perspective, why we've had to kind of define the kind of qualifications that, pretty steep right now, but not in all trying to hold people out of it. It's just, that's the way we have to start.
Yeah, thanks for clarifying that, Dave. And so what happens when you're done training? How does it allow an HC, like what does it allow a healthcare professional to do when you're done the didactic and experiential?
You mean from the point of view of practice then?
Yeah.
Yeah, so I mean, under the current order of things, you become affiliated with TheraPsil, and through Natasha's kind of work, she's the initial screener of patients. She kind of does intake work, and then she would contact you if you're part of our network and say, hey, look, we've got a patient, so and so. Would you be willing to be part of the team to make sure it's a good fit? And when that person gets an exemption from the health minister, then the therapy can then move forward, assuming that you have your exemption to do the work. And we are trying to work really hard right now, not just TheraPsil, but a number of organizations to create some sort of national network of psychedelic professionals so that we can be connected to each other. Trainings, like you said, that we're offering. I think both peer supervision, consultation, and professional supervision will be really, really important. We do not want people feeling like they're practicing in a silo by themselves. This is new work, it's challenging work. So it's a very high value to all of those in our network to be connected and feel like they've got answers. Now, you can just say, be quiet, Dave, it's fine. But we're also aware that on another level, that therapists are going to be able to start seeing folks without too much fear of kind of criminal prosecution. The way that it stands right now is that it just so happens in Canada that people can go to places like the mushroom dispensary either to get their own mushrooms. That's if they choose to do that, if they want to purchase the mushrooms. So if they bring the mushroom to me as a therapist and say, look, I want this I'm going to take these mushrooms, I want to do it therapeutically, I can do it within the harm reduction model, right? So I'm not making a judgment on what they're putting into their bodies, but if they choose to put something in their body that has some risk associated to it, I want to make sure that they do so in the most safe, efficient way possible. That's the harm reduction model in this kind of purest form. So we're able to provide that. And so, I mean, I don't want to go too far down that because it's still, super undefined, but I just know from personal experience for a lot of people that get trained, they start seeing people even outside the Health Canada framework, which is, a choice that they make to do. And we don't tell them to do it or whatnot, but Bruce has got a huge heart for this movement and, wanting to support those people too. We don't want them by themselves. We want them connected into a larger network.
Mm-hmm. Yeah, and I think that's why regulations are so important.
100%.
We can bring everything above the ground and everyone can feel safe and supported for sure. Awesome. So there's so many questions. I'm glad we've got 20 minutes. Some that got sent in before, some that have been trickling in, and feel free, folks, to keep bringing them in.
I saw one that interested me. Let's see. Oh, nurse practitioners. Can I just because I have as Yasmeen knows, I have a very special place in my heart for nurses. My wife is a nursing prof. Most of the very important women in my life and men, I've got a great friend, two of them were nurses. I think nurses, by rigor, by discipline, by training, bring a presence to a medicine session that is unique. And I think there's a kind of a growing interest within a number of nurses here in the Lower Mainland to begin really trying to understand that, because I'm very interested. I'm not a nurse, so I got to kind of be on the sidelines of it, but I'm really intrigued. So my life partner is a nurse and a nurse trainer, and when I hold space with her, there's something going on that is just substantially different in a positive way. And so whoever asked that question, nurse practitioner, absolutely you qualify for our training, and you could be kind of a pioneer in a sense, beginning to say, hey, 100 years from now, we'll say we wouldn't even consider doing psychedelic medicine without a nurse presence there, right? So the folks who are now in this call beginning to wonder, hey, maybe that's for me, that'd be great. I think. Absolutely,
Dave. I couldn't agree more. And just seeing Natasha, our clinical intake director, with one of our patients, it's a beautiful thing. And Adele, Dave's partner, is an unbelievable nurse too, who's involved in our movement. and involved in our team. And yeah, we don't know where we'd be without nurses. So thanks for sharing that, Dave. And so one question that came through was, what if we're not feeling a readiness when it comes time for experiential session? Can an experience be delayed if we're not feeling like it's the right time?
Are you talking, now you may not know, are they talking from the point of view of the therapist or the client?
I think the therapist in training for the experiential session.
Okay, so I think that's just a rule anyways. The readiness is such an important part of this, and we don't want people to feel pressured, rushed, coerced into a medicine session. It just doesn't work that way. It has to be a robust choice of yourself to say, I think I am ready. And we always want to be careful not to scare people away or anything like that. But I think all of us intuitively know this is powerful medicine.
Yes.
And I've said, compared to MDMA, psilocybin's a bit of a bully. When you're like, you say, hey, you come with me, right? It's sort of it's good, and it's not a bad thing, but people intuitively know that it could be a very intense. And so personal readiness is such an important part of it, where regardless of, if you're moving to the retreat and you just kind of say, just not feeling that I'm ready to do it, we absolutely will say, that's fantastic. That's such good self-awareness on your part. And when you are ready, we're here for you. You can also hold space for people under the supervision. So we would want to accommodate that. And just, again, I think we would just be maybe a little disappointed for them if they're, because maybe they came in wanting to do that, but that's life. And, I think feeling its time is a big part of the experience, I think.
Yeah, I couldn't agree more. You don't want to rush it. You don't want to push your boundaries. And when it feels right, it absolutely will be right. Yeah. Another question that came up is, and I'll just answer the first part of this, is how would it be, or is it possible for someone like myself who is not a medical doctor to become certified in psilocybin therapy and administer psilocybin therapy post-certification? So currently we're accepting folks, like I mentioned earlier, who have a master's degree or are a medical doctor around and experience with psychotherapy. And something to note is you'll never actually administer the psilocybin. The patient will hold their own Section 56 exemption, which allows them to possess, consume, and destroy and transport psilocybin in the context of their experience. So they'll actually, currently for our Section 56 exemptions, they'll procure the psilocybin and then they'll also ingest it themselves. Anything else you want to add there, Dave?
No, good.
Good. Okay. And how will your program prepare its graduates for practice in psychedelic therapy?
Well, again, that's going to be such an ongoing part of it, and I think the first step is let's get some sort of professional stream together, and because it's going to happen quickly. I mean, 2 years from now, this is my opinion, Yasmeen, 2 years from now, I think we're going to see therapists able to hang out kind of a shingle and saying, yeah, I do psychedelic medicine and or therapy, and folks will just be able to go to them. And I think that's within 2 years. And so to be able to help all of us together learn how to do that in the most safe way, not just safe for the client, but also safe for our practice, safe for our certifications, safe for our families, I think that'd be really important. Absolutely. We continue to try to understand, because only 3 or 4 years ago, all of this was deep underground. The therapists were offering this work at real personal risk, right? That if they were to be found out or whatnot. I don't think we're at that place anymore. And I think in 2 years we're going to even notice it'll be hugely different than it is even now.
Awesome, thanks, Dave. And would you consider accepting pharmacists?
I mean, for sure. I mean, that's an interesting question. I think, again, we need pharmacists in this field, and pharmacists have a professional rigor, so they're able to kind of go through my training and learn it. And if they're gifted, why not? Mm-hmm. Awesome. But I probably their interest is going to be more on the neuropharmacological end of things, which again is we do need to continue research into what's going on inside of the psychedelic trip, different kinds of psychedelic substances like ketamine, ibogaine, mescaline, doesn't matter. We're really interested in these different, how they work, what populations they seem to work best with. That's really, so pharmacists could be just wonderful in that space.
Mm-hmm. And I think when we do get regulations, I think there will be an even bigger need for pharmacists in the psychedelic.
Yeah, because you can see that, like what you just said is right. The
Yeah.
patient's got to procure their own or whatnot, but you can see the next step past that.
Oh,
Like
yes,
that's unfair to the patient. Why don't we just get some sort of standardized psilocybin that pharmacists can give them, right? That just seems like the next logical step to this.
Absolutely, and that's when I can see things perhaps shifting from a pharmacological lens. We also got a question about paramedics qualifying.
Yeah, right, I have a paramedic in, I think it's our Atlantic cohort.
Yeah, he's also a counselor. So right now they technically don't qualify. But as I mentioned, we do have the 2-day intensive that we're planning, and hopefully that could be a spot for paramedics.
Okay.
So Dave, if one reacts strongly to THC, will they also overreact?
Okay, just do it again. You're a little choppy there. Just try that once more time.
If one reacts strongly to THC, will they also overreact to psilocybin therapy?
I've heard that. It's outside my expertise. I've heard that there is like a general kind of connection, but that, I think personally, Yasmeen, that's probably more relates to recreational use. Therapeutic use of psilocybin is just different. It's not just the actual mushroom that's working here. It's the playlist, it's the intention setting, it's the energy of the guides holding the space, it's the healing that's going on inside. So even for folks who may find mushrooms bumpy, and I'll be real honest, I don't quite like recreational mushrooms. It's not a fan.
Yeah, it's a totally different experience.
Yeah, and everyone's life. So, but even so, I've had 3 therapeutic mushrooms experiences myself, and they have been life-changingly and powerful and hard, but super great. So it's almost like it's hard to really use the cannabis to psilocybin comparison, although I've heard that there might be something there for recreational use.
Awesome, thank you. And someone also asked, is it ill-advised for someone who's on Prozac to take psilocybin without tapering off the drug?
This is a tricky one right now. So I'm part of a research project that's going to be looking at that very thing. It's starting in 2022 of psilocybin with SSRIs and non-SSRIs depressed folks. Right now, it's an exclusion, and it requires people to taper off their antidepressant. But Robin Cardaris and others are saying that could be just as problematic for folks. So I think a good kind of secondary option for folks on antidepressants is ketamine, because that's not an exclusion for ketamine therapy. And I think we are going to find in our study, because Carhart Harris just did one of his own around the same thing, his studies showed that there's no danger. So it's not a dangerous thing to be doing SSRIs and psilocybin, but it does seem to tend to mute or kind of hold the experience back some way. And so that is obviously going to be studied, like, well, how can we help that along? I think the safety issues with SSRIs really have more to do with MDMA therapy. And I think what's known as Serotonin Syndrome is more relevant there. Although even that is you get into kind of the journals on it, there's lots of disagreement on that as well. But one of the interesting things about psilocybin, it is really one of the absolute safest substances on the planet.
Yes.
They give scores to the morbidity of these things, and it's one of the lists. It's safer than cannabis. It's safer than almost any other psychedelic, and so it just seems to, you can't overdose on it. There's been, like, other than in the 60s, anecdotal stuff of folks dying because they were in unsafe places while they were high. Psilocybin itself is just a very, very safe and very stable substance.
Mm-hmm. Yeah, thank you, Dave. And one question that I can just answer, and we get all the time, is how can I find out where I am on the wait list, and how long do you anticipate it before I access training? So with our in-person training modules, we're, for the next year or so, until we get really comfortable with the in-person training model. We will be accepting 12 people per cohort. And the reason why I can't really give how long we anticipate it will be, there's currently 1,000 people on our wait list. But that being said, we go through our wait list first on region, and then second on time of sign up. So there's 1,000 people on it, but let's say our next cohort's on BC. We're not emailing anyone from Ontario, so maybe we'll skip from number 3 to number 20 to get to that next person who's from BC. Good news is we do, with having more trainers on now, we anticipate being able to scale at a higher rate, and we'll still be probably building our training team larger, so there'll be more scaling opportunities. And also lots of folks perhaps were interested in training last year and they're not this year. So it could be sooner than you expect in when you get that email, and then you can apply. There was also a question about, will there be a French training cohort? Our Montreal cohort was on the week of November 15th, and the folks there all speak French, and some of our trainers speak French. So if you are in Montreal and speak French, there is an opportunity, and we hope to launch more trainings on the East Coast soon.
Hey, Yas, a couple of chats came in about serotonin syndrome. Let me just kind of address that really quick. First of all, I'm not a neuroscientist, okay? So everything that I know, I've gleaned from what other people have said, but my understanding is because psilocybin and MDMA bind to the same neuroreceptor as an SSRI, which is serotonin 2A, there is some concern that that could have an effect on the heart. And that's known as Serotonin Syndrome. Again, there's lots of disagreement whether there's actual a thing called Serotonin Syndrome. Some people say it's not even a thing in the MDMA world. It's thought to be something we have to, through safe practice, just exclude folks right now. But there's some belief that probably, again, isn't a major risk factor. And I think right now, psilocybin, Carhart-Harris's studies and whatnot have shown that psilocybin is not unsafe with serotonin 2A, but it just may not be as effective. And then ketamine is fine with SRIs because ketamine binds to the glutamate receptor, as far as I understand it.
Thanks, Dave, for that clarification. I just saw a question come in. Do we plan to do training in Ontario? Absolutely. Dave just finished 2 cohorts in Ontario this week and last week. Thank you again, Dave. And there was
very active scene in Ontario.
Yes, very active scene in Ontario, and we do plan to scale. So there's future cohorts there. So absolutely. And then someone also asked, while we're on the eligibility, do you have to be a Canadian citizen to do the training? Right now, yes, you do. Perhaps that will change in the future though. And so we've got 5 more minutes. So I'm going to be mindful of our time and just try and get a few more questions and squeezed out of you, Dave. Can you comment on the cost of psychedelic assisted therapy with psilocybin, all sessions included? So preparation, integration, and the dosing session.
Yeah, it's probably in the neighborhood of $2,500 would be just a rough ballpark. That's just paying standard therapeutic cost to therapists, and that's and whatever the mushroom might cost. Most therapists that are in this space are pretty aware of accessibility and not wanting cost to be something that gets away. So lots of organizations are trying to put together kind of funds and funding agencies that can support folks who can't pay that. It would be great if we could say it was part of medical services plan. It's not, and probably won't be for quite a while. So I would say $2,500 is probably a good ballpark figure.
Awesome. Thanks, Dave. And can you touch a little bit on extended medical coverage and how that might impact the cost of training? Okay.
So again, right now, if you see your therapist from a harm reduction model, then that is covered under, if you have extended benefits. Most RCC therapists are covered with extended benefits, so that would be covered. Again, the medicine session is quite a few hours, and again, I'm going to say that probably most benefit plans won't accept the many hours that session would cover, but some might. yeah, so there is the avenue of some support that way for some people.
Awesome. Thank you. Where else can we get here? Okay.
I saw some of microdosing, just throw my 2 bits at microdosing. Microdosing is really interesting. And I think, probably 20 years from now, we are going to say, wow, there was way more to microdosing than we thought at first. The problem with microdosing, it just hasn't been researched yet. And so right now you're seeing in schools all across really the world, but certainly in North America, students and folks beginning research projects looking at the efficacy of microdosing, because of course the great thing with microdosing is there's no risk, and you can continue to be on your medications. It's below threshold, but having said that, there's so much anecdotal evidence that just says, wow, this could be amazing, and not just microdosing psilocybin, microdosing LSD, microdosing cannabis, microdosing iboga. There's just a lot of smart people are saying, hey, we want to see the connection, but it's just interesting that microdosing just hasn't been studied. So everything that you're going to hear about and read about is anecdotal. Doesn't mean it's false, but it just means we just don't know right now. And if you are thinking of microdosing, which I think is great, I recommend the James Fadiman regimen. So you just Google that up, and it's just a really nice kind of, most of us in this space will say that's the one we say, go use that regimen, which is twice a week for 6 weeks, take a break, journal, this kind of thing. So it seems to have the best. And microdosing seems to impact, psilocybin and LSD seem to impact mood, focus, and energy. And some people say creativity too. So those are the domains that seem to be most impacted by microdosing.
And read the book A Really Good Day.
Isn't that a great book? I love her. She's so good. Yeah, A Really Good Day. It's
A Really Good Day. It's all about microdosing.
And she's rah. So
she really is, and she goes through the whole protocol. But
she's an investigative kind of lawyer human, so she, she's careful and she wants to make sure the science is there. So it's really, really well done. Yeah, I agree.
Absolutely. And one question maybe we can tag team, Dave, why are the regulations proposed? This is probably the last question we can get to of the evening. Why are the regulations proposed by TheraPsil and the CPA different? Isn't that a bit counterproductive? Clearly, both will not be approved. Thoughts? So from a TheraPsil standpoint, we are going to try and work together with the CPA to with those regulations. I think the biggest part that's different is we don't think that patients should have to do their treatment in a clinic. We think they should be able to do their treatment at home, and they should be able to grow their own grow their own mushrooms. So that is the biggest difference, and we absolutely support everything the CPAs do.
I think the main thing, we are all on the same team. That to me is like one of the beautiful elements of this, call it the spirit of the mushroom, is that we kind of let our egos go a little bit. We're more about cooperation, and of course TheraPsil, we got our little space in the world. We're trying to do what we're doing, and CPAs try to do what they're doing, but we're trying to do the same thing. And the more we work together and move together, the better it'll be for everybody.
Absolutely, I couldn't agree more. Well, thank you so much, Dave, for all your time.
Yeah, it's been great. Yeah.
Thank you for all the questions, folks. Thank you for joining us. We are thrilled to have you all here and for your continued support. And Dave, we are so grateful to have you on another webinar. And
I'll tell you, I can't believe at this point in my career that this is what I get to be doing. Being part of something beautiful, something that's global, something that's really helping people in meaningful ways, and that I get to do what I am good at, which is training. I just feel like, pinch me, how did this happen in my life? So it's so great.
Well, and we're so lucky to have found you. So thank you. And thank you, folks. Yeah. If you have any questions, you can email us at healthcare@therapsil.ca. And please advocate as well. Join the advocacy movement, and we will see you next time.
Good night, everyone.